Hi there, my name's Jeremy Uzi. I'm a podiatrist from Berkshire, England. I was on a foot pain forum earlier today and I came across an interesting thread which I thought I would respond to. Forgive me, I'm on my laptop using my webcam to record. So I am going to be kind of between my script and everything else on this video. So, just to start off with, I'll introduce myself and my qualifications so that people know where we're coming from. I am a podiatrist, so I've done my bachelor's in podiatry. I specialise in musculoskeletal podiatry. I've got a postgraduate degree in pediatric sports medicine, a master's in the theory of pediatric surgery, and another master's in sports and exercise medicine. And I've got another postgrad in medical ultrasound, and I'm about to embark on another degree. So I'm on this forum, and there was a guy, he seemed a bit unimpressed by his specialist, and since it could quite easily be me that ends up causing someone to feel a bit unimpressed one day, I thought I'd do a little response to the whole situation, so that way, people can see where we come from when we're looking at your feet. So I'll start off reading the comment. Hi all, I went to see a specialist last week for my plantar fasciitis. He examined me by telling me to push against him in several ways. He told me I haven't got plantar fasciitis. He asked me where my pain is, and I told him it's from my heel to my little toe along the outside. He told me I don't have plantar fasciitis, so he wants me to go for a scan. If that doesn't show anything, then I must go for an x-ray. Can anybody help me here, please? My foot is so painful to walk on, whatever the problem is. Standard story for me, every single day. Only reason I put the specialist in inverted commas reasons. That's what the OP did with their grammar, and also certainly some people are probably quite specialised, and as we go through, I would actually be inclined to agree with the person, whoever it was. I've assumed podiatrists sometimes. I'm inclined to agree with them, so I'm not going to fault them for that. And I'd say maybe actually this guy he's seen as possibly a little bit better than he's given credit for. So anyway, here's my thoughts. I would agree it's probably not plantar fasciitis because the plantar fascia doesn't span the outside of the foot. So when we're looking at a foot, here's my model foot. Patients who don't pay their bills, this is what happens. I'm kidding. So the plantar fascia, this is the inside of the foot where the big toe would sit. This is the outside of the foot. So the plantar fascia, it runs from here to here. You've got another band running from the central portion of the heel up through the middle. Then you got another part which kind of comes through and runs a little bit along the shaft of the fifth metatarsal, this long bone here. First thing I say is that going for a scan, it's a good shout. Probably a few other tests that I would do personally clinically before sending for a scan. But then what we do as podiatrists or health professionals is we kind of do all these tests that you don't realise we're doing. Feels like we're just rubbing your foot or poking at it randomly, looking a bit confused, quite possibly. And so it might be that he was doing tests and you just had no idea he was doing them. We kind of wait to see if you flinch or stop talking or jump out the chair or whatever, and that's a good way of identifying things rather than having you focus in on everything else we're doing. So OP, they say he examined me by telling me to push against him in several ways. Likelihood is that he was testing the tendons, seeing if any of them were hurting whilst you were pushing against him. And again, brilliant place to start. He's also probably checking the strength of various muscle groups and ensuring you don't have anything else going on alongside your foot pain. So, if you've got muscle wastage, etc., then that's something useful to pick up on. I would also probably be going for a scan. I would probably aim for an MRI scan. I might even consider getting both feet done. That's more costly. It does mean there's a comparison. So if there's any muscle wastage or anything like that, then it gives a A-B comparison type scenario. So you can check if the muscles are the same thickness. Don't know about the x-ray, depends what he was thinking. Often x-ray goes first, then MRI, just because x-ray is cheaper. And like the radiation exposure is pretty minimal. So I would normally go with that, but equally an MRI scan, it's going to show everything, possibly even too much. And then we had a helpful commenter. So they've suggested, hey, look up tarsal tunnel, which I assume is tarsal tunnel syndrome. I've been seeing a doc for a while and now being tested for this, treated for this even, after a long time thinking it was plantar fasciitis. He also says it could be scar tissue from plantar fascia pressing on a nerve in the foot. Tarsal tunnel is a good shout. Probably wrong, but it's a very good shout nonetheless. So the tarsal tunnel, it's a space through which a number of structures move from ankle to foot. A lot of the tendons and the nerves and the blood vessels that supply the foot come through the tarsal tunnel. So again, big toe joint here, or big toe on this side, little toes on this side. The tarsal tunnel runs along this area, along here. So you've got 3 tendons, 1 big chunky nerve, which is about the size of your little finger, pretty thick then, and a few blood vessels that run through there. So anyway, lots of stuff going on in that little space. And if you've got something that's a bit swollen, then it can very easily press on the nerve and then cause pain to occur. So yes, could be, but unlikely to be the tarsal tunnel. The commenters also said she was told that the scar tissue is pressing on the nerve. I don't think so. I'd be surprised in her case if that is what's going on. But it could be that the thickened plantar fascia is pressing on the nerve or causing compression on it. The reason I say it's unlikely to be scar tissue is because very few people actually tear their plantar fascia. But we've not got any history to go on, so that being said, a condition that can occur is Baxter's neuropathy, Baxter's neuritis, and that's where the nerve that passes from the tibial nerve, it comes under, round about here, and runs under a muscle in the foot, and comes across and supplies this outer border of the foot. That is quite possible. That'd be pretty high up on my list of differentials, i.e. things that I'm considering as a diagnosis, based only on what we know already. But the plot thickens. So, original poster, thanks for that. Never heard of it, but I've written it down to mention to my GP. This is where it gets good. I twisted my ankle, and from that it hurt, and I spoke to my GP and he said I've got plantar fasciitis. So I went to physio. They also told me I've got plantar fasciitis. Recently I was told I haven't got it. So history is everything. Everything. Put that down. Our protagonist, our original poster, he said that he's twisted his ankle and the foot pain started. Most people have an inversion injury rather than an eversion injury. So an inversion injury means that the foot, so big toe on this side, goes, that's you kind of walking along in heels and going, tightening over. The other injury is an eversion injury, much, much less common. And that's where you go like that. So big toe kind of ends up rolling in. So what happens is that when you have an inversion injury, you've got this happening, because normally you'll go over the ankle, so it'll be kind of a maneuver. So again, from here, so it gets stretched all the way along this bit, along here. And you've got one particular group of tendons called the peroneals. They run down the back of the ankle bone, just along here, round the outside of the foot. One goes in here, one comes down and under and up that way. Okay, that becomes stretched. So that's a really common one to have issues with. I'm going to put a slide in here. Common issues. Might do a little voiceover for you too. So, just as a quick run through, the common injuries are the ruptures are of the anterior talar fibular ligament, which is a ligament at the front of the ankle. That one's quite commonly injured. And the calcaneal fibular ligament is a ligament at the side of the ankle on the outside. That one is common, but not as common as the ATFL. fractures, big and small. So a big one would be breaking a big bone, whereas a small one would just be cracking a bone or maybe just pulling a small bit of bone off because of the tendon tension. Injury to the peroneal tendons, just kind of like a sprain or strain, whereas re-injury would be you've stretched the tendons, they're no longer as stable, your foot doesn't know where it is anyway, and so you end up rolling over that foot on a regular basis in the short term. Less commonly, we've got cuboid syndrome, which is kind of like a compression type injury. So there's a bone in the edge of the foot which can become compressed as a result of dysfunction. Equally, sometimes it gets a bit stuck and the tendon, one of the ones that goes down and under across the foot, pull on it awkwardly. Sinus tarsi syndrome is this little space inside of the ankle, just kind of between the ankle bone and the heel bone. And tendinosis is where the tendons have been injured and then they move into a chronic state of injury, i.e. they've been injured for more than 3 months, and so you start to have changes occurring. Chronic ankle instability is this idea that once you've sprained your ankle, unless you rehabilitate it incredibly effectively, what happens is you keep on re-spraining it or re-rolling over it because your ankle kind of forgets where it is meant to be, and so that can be quite problematic, and it's a big cause of ongoing issues, injuries and morbidity. At that point, I'd be surprised if plantar fasciitis was ever anything occurring in the care. Wasn't there, didn't assess you, didn't hear what was said by anybody, didn't poke around or anything, so can't honestly say. But I know people will say, look, it's plantar fasciitis, partly because they don't know what to call it, other times because it's just easier. The shoes are pretty similar for peroneal and tibialis posterior tendinitis, so either side of the ankle. The shoes, the insoles can be pretty similar as well, depending. The treatment strategies are all pretty similar, so don't know. Could be incompetent, but could also just be a way of explaining it for you. Next comment from the original poster. I've just looked it up, and looking back, the doctor asked me if I'd had back pain any time. I've only had back pain when I've done lifting, but it soon goes. Kudos to your doctor. Great job, Dr. Anonymous. Great to ask about back pain. Quite a few patients, they come in with heel pain or something like that, and it's actually back pain, so good job to them. Bonus points for getting that, even if they got the diagnosis wrong about plantar fasciitis. Reason being, number one, cauda equina, very rare, thankfully. It's a condition where the spinal column becomes narrower, compressing the spinal cord, and effectively prevents the blood from getting there, and as a result, spinal cord dies. Bit of a problem. Kind of like a stroke, but in the back. Problem number two, depending on your age and what your family history is and all a load of other stuff, if you get back pain, it predisposes you to, or you might have another condition called ankylosing spondylitis. Rare, don't worry too much, but it follows kind of a very specific pattern. And when you've got that condition, it predisposes you to enthesiopathies, i.e. tendon problems. So brilliant that your GP asked. Hopefully he was thinking of that. And the tendon problem is very specifically when the tendon inserts into the bone. So when you've got a tendon problem that's not resolving and you fit a load of criteria for me, I kind of go, let's get you some blood tests and maybe send you to somebody very, very clever called a rheumatologist. Not necessary, probably in 90% of cases or more. Then it gets a bit more interesting. In fact, we'll say the plot thickens, and if this was a river, it's mud. It's so thick. I have also had aches in my leg due to starting new jobs and having to walk a lot, but not being told anything about tarsal tunnel. Let me go and say that again. I've also had aches in my leg due to starting new jobs and having to walk a lot. That is the number one cause of foot pain and tendon problems in my opinion. In fact, problems throughout the rest of the body. Wherever it is, you do too much, it hurts. When we overload a structure, we cause small amounts of damage, and then the body responds by healing it, and it kind of over heels. So it's kind of like that principle of bodybuilding or getting stronger. You go to the gym, work out, push it a little bit, make sure that your muscles are tiring and aching at the end of it. You go home, have a hot shower, sit down, do nothing, go to get up, and then you go to bed, wake up next morning, and wow, you're stiff. Takes a couple of days, settles down. You have a rest day or two, all better. Now, you look at it from the other side of you go to the gym, work it hard, you then start work the next day, you're also a builder, so you work it really hard. And then you have 3 or 4 more days of doing the usual stuff. And then you're going to really, really push it. And, if you're doing too much, you're going to ache anyway. And you then push it way past what it's capable of. And it's sore. That's what it comes down to. Same thing, like if I said to you, hey, go without sleep for a night. Yeah, you could probably function 1 coffee, 2 coffees, 8 coffees later. You're a bit cranky, but you'll get by. That's kind of your slightly grumbly, achy tendon at the end of the day. You do it for 2, maybe 3 days. Well, people are going to avoid you. You'll probably avoid people too. Everything's exhausted, right? We know that this is a big thing because we also know that rest gets things better. So what we have to do is we have to make sure that you rest it just enough, not too much. So we talk about relative rest. Relative rest is this idea that there's so much you can do before it all hurts, even more. So if you do less than that, you get by. If you don't do less than that, and you do more than that, you won't get by. So if you are used to having 10 hours sleep, but you then drop down to 8 hours sleep for a week, you'll probably be all right. But then you find that if you do it for 2 or 3 weeks, not so easy. If you are used to carrying a bag to school or to work or whatever, and you then double your bag, same size bag, same weight, you double it, that's a 100% increase. And so then you end up hurting yourself. So what tends to happen is as people start walking, they start a new job, they go on holiday, they change their shoes, change the floor at home, whatever it is, they then increase the amount of work that the foot does. And in increasing the amount of work that the foot does, they then overload it, and then they carry on doing everything they normally do. So my number 1 top tip every single time when dealing with this stuff, reduce what you're doing a bit. Doesn't have to be much, just do it a little bit, okay? You have to identify just how much it is that you can do before it hurts. And the best way to do that is to see what your morning pain is like, and then when you see what your morning pain is like, or your pain at the end of, or when you get up from having sat down for a while, this is the pattern for tendons typically, you then start to nudge it down or up accordingly. So let's work through an example. Pre-injury, so-and-so can do 10,000 steps. He injures himself, goes on a long walk. In fact, he goes on a really long walk, goes shopping with his mum, and does 20,000 steps in that day. So his foot aches a little bit by the end of the shopping day, goes home, puts his feet up, goes to get up, he's stiff, painful, ouch. Fine. Next morning, goes to work, does his 10,000 steps. So now he is already 1 day ahead of his usual 10,000 steps. And he does that every day that week. And it still remains sore. And then he goes off again on the weekend, does a little bit of a hike around, does 15,000 steps on Saturday, another 15 on Sunday. So again, over that weekend, he's now 1 extra day ahead as well. So he's done 9 days worth of walking in 7 days. It's not sounding good. Not sounding good. So he then finds that he wakes up on Monday morning and he's in huge amounts of pain. Really, really sore. And the problem is that at this point he has gone over the maximum workload that he can cope with. So instead, what he should be doing is trying to work out what he can do without it hurting. So he then has a really lazy day, does 5,000 steps. And wouldn't you know it, he wakes up Tuesday morning and it feels better. Not amazing, but better. So he then goes for it, does his usual day, 10,000 steps, wakes up Wednesday morning and it hurts. You see where I'm going yet? So what he should do is do, okay, 5,000 steps on Tuesday morning. He goes, okay, this is good. Let's do 6,000 steps today. So he does 6,000 steps, and maybe he gets away with it, maybe he doesn't, whatever. If he gets away with it, maybe stick at 6,000 for a day or two, move up to 7 on Thursday. If he doesn't get away with it, drop back down to 5, maintain it for a few days, and then after a few days, just try it at 6. See if the pain goes up or down. If it goes up, okay, nudge back, rest it, maybe look at other ways to take the pressure off, so shoes, insoles, stretching if necessary, but probably going towards strengthening and stuff like that. All of these things can really, really help. Using ibuprofen, that'll help to reduce the inflammation. I'll do a little talk about that, but ultimately, there's so many ways that this can be reduced, but the first thing, most important thing, is to rest it, but only relatively, because if you rest it too much, muscles atrophy, the tendon will respond by healing to the point of the amount of work it's doing whilst it's resting. Much like your little old grandma, she probably was once upon a time quite fit and healthy, but then she stops doing all the exercises that she used to do, so she loses her fitness, finds things are heavier when they weren't really that heavy once upon a time for her. And as a result, the body deteriorates. You then get the guy who goes to the gym a lot, starts lifting heavy weights, gets used to it, and as a result gets stronger. The body adapts accordingly. So what you need to do, work out what you can cope with. Don't go any lower than you need to. So if that means that you start, let's say you can't walk at all, you're doing 2,000 steps a day and that's still pushing it, make sure you change your shoes, because shoes are important. Look at a bike, look at any other exercise that you can do, just to maintain the cardiovascular fitness. Consider doing non-impact type exercises, weight training, stuff like that, and then boost yourself up. Anyway, that's going into a whole other video for another day. So hopefully this explains most of it. And I can do another video response if necessary, but I'm hoping this should answer most questions that you might have. Thank you so much for watching. I really do appreciate it. Every video that gets watched really, really helps for my channel, but I am doing this to try and raise awareness. I want to see people get better. That's the ultimate goal. Doing these videos, it does take time. I've had to record this twice because the first one absolutely went to pot, technology failure. It helps a lot if you can like the video, subscribe, even just put a comment on there if you tell me it's rubbish. I don't mind, but it does help a huge amount. So hit the like button, hit the subscribe button, share it with your friends, and hopefully that means that I can continue helping you.